Good afternoon, everyone. I'm thankful to organizing team to give me this wonderful opportunity and wonderful hospitality also in the beautiful lake city, Udaipur. Uh, I would like to invite my panelist, Dr. Ashish Kaushal. Is he here? Dr. Preeti Agarwal, my colleague from Jaipur, Dr. Sachin Jain, medical oncologist from Udaipur, Dr. Ankit Agarwal, again from Udaipur, Dr. Manish Gautam, is he here? And Dr. Narendra Rathore. So it's a little bit different way to have the panel discussion that they are sitting the other side, but believe me, they are more important. I'm at little higher on the higher side of the stage, but it's not that way. They are more important, and I will request all the audience that whenever they have anything in the mind, they can interact, pause it, and can have the question answer session. So for sake of starting the things, let's have the case scenario. Let's say that we have a 65 years old male patient, and it's a routine way of the presentation of the prostatic malignancy. That patient had the back pain, and evaluation was done, and he was found to have the prostatic malignancy, biopsy done, adenocarcinoma, and then subsequently the staging workup with the help of the PET CT scan is done, and it turns out to be the bone metastasis. Visceral mets were not there, and the biopsy suggested Gleason's score 4+4, 8. And PSA upfront was more than 100 nanogram per ml. So this is the routine case scenario we see in our clinics. Almost everyone see the prostate presentation like this. So let's have the discussion here at this point only. Dr. Sachin, how would you like to evaluate this patient further? What else you would like to know from me before I try to start the management of this patient? Back pain is there. There is no sort of the emergency, no radiation, no compression. Prostate symptoms are minimal. With the low backache, patient evaluated, histopathology, staging, PSA. 3 important things are with me. So what you would like to do more investigations as on today, October 2022?
Sir, as the FDG PET CT was done either because of the availability, plasma PET CT as indicated in these patients, and other biochemistry and other blood investigation if they are normal, and then we can plan for treatment. Sir.
So this patient FDG PET is done. There are no visceral metastases. So if I ask you again, what the difference you would like to see in the PSMA PET versus FDG PET in this patient, which is going to change the scenario of the treatment for this patient?
Possibly no difference, but as per recommendation, the plasma PET is indicated, otherwise no other
So Dr. Ankit, you would like to add anything? In this particular scenario where the patient is sort of diagnosed as the prostate malignancy based on the biopsy, PSA, clinical examination, it's well taken that the PSMA PET is the modality of the choice. But in this scenario, still do you feel that we should do the PET CT scan?
Sir, I think first of all, I would like to know how many bone metastases are there, whether any appendicular skeleton is involved or not. That is first thing that I would like to know. Calcium levels would be one thing that I would like to concentrate on. I think that should be it.
So Dr. Manish Gautam, so how you try to differentiate the number of the mets, bone mets, and then try to do the evaluation of the patient for suitability for the first line treatment?
Sir, if there is involvement of the long bones or appendicular system, then there maybe we go for symptomatic relief and for the bone pain and other things. So I required to know that there is appendicular system involved or not.
So that's the one point that you want to see, that the long bones or the weight bearing bones are there. So in continuity to that, I would like to ask Dr. Narendra Rathore that when this patient is being evaluated by you or is in the multimodality treatment, how you judge that the patient needs upfront irradiation? Is it only the pain, or how do you evaluate that the patient need to be given the irradiation, even let's say that we rely upon on the combined androgen blockade? So how you evaluate it?
Sir, we think that whenever the patient having bone metastasis in weight-bearing region, especially there is a spine or femur neck, radiation, even patient having no symptoms like neurological symptoms or impending fracture, we have to give the radiation to that area so that patient further skeleton-related event can be prevented. So
do you do sort of the MRI or some sort of the CT scan to see the cord compression, collapse or fracture, or based on the standard uptake value, which sometimes remains very high in the bones, you judge the patient for radiotherapy, or how you evaluate the patient? Because the patient may have the florid mats, sort of like if you do the bone scan, there may be the super scan, that all skeleton, everything is gone. So how you evaluate the patient that this particular area you need to irradiate? Because as on today, we have the number of the drugs available, cytotoxic drugs for the prostate also, like docetaxel, mitogentone, cabazitaxel, which we try to give sequentially. So how you keep in the mind that the patient need to be irradiated minimum possible to spare the marrow?
so usually we give the radiation to the when the bone marrow, when the cortical thickness or the shortening of the bone, if the impending there. If suppose the cortical thickness is less than 30%, then we try to keep the patient on radiation so that further impending fracture can be prevented.
Dr. Preeti, you want to add anything here?
So, apart from pain and neurological symptom, if there's the soft tissue, the spinal soft tissue is much and patient is having significant neurological symptoms and the patient having disease at the weight bearing area, yes, radiation. We sometimes do refer patients for radiotherapy.
So coming to the hormonal therapy in this scenario, androgen deprivation therapy, again to Dr. Preeti Agarwal, how do you choose in the first line, or even before that, would you like to do anything evaluation on this biopsy material or blood test as on today as the standard protocol?
So yes, you have correctly written, we would like to go for HRR testing on the biopsy, for somatic testing, or in blood for germline testing.
So how do you choose the androgen deprivation therapy, Dr. Gautam?
Sir, the ADT can be choose on the basis of what is the symptom, what is the patient's presentation, and 3 category 1 drugs are available, docetaxel and LHRH agonist and LHRH antagonist drugs are available.
So Dr. Sachin, when you discuss with the patient for the androgen deprivation or blockade, between the surgery versus these analogs or the agonist or combined androgen blockade, how do you go with the patient or choice of the patient, or how do you choose between surgery versus the chemical castration?
So personally, I would prefer surgery because it is a one-time investment, you can say, and we can follow the patient after this orchiectomy with regular investigation and then monthly zoledronic acid or denosuzumab, and the financial toxicity is more in medical castration. But if patient is willing for medical castration, then we would prefer medical castration. And
So
nowadays in Rajasthan, as per Chiranjeevi, both can be done at free of cost. So there is no financial toxicity. So it's patient's choice what he wants at the end.
So what are the medical toxicity difference between the two, surgical and medical?
Financial toxicities are
Medical toxicities, other than forget the financial toxicity. Do you find any difference between the surgical castration and long-term toxicities or GnRH agonist?
There few patients are on medical castration and they are comfortable and they have at present no complaint of
Any other comment from the panelist side on this point?
I don't think I've seen any long-term toxicity.
So
Only thing is a patient who gets started on a LHRH agonist, we have to counsel that till you live, you have to take that, because even in CRPCs, there is a
So
data that we have to continue.
So there are certain suggestions that the cardiovascular toxicity, including the mortality, is more with the medical castration, contrast to the surgical orchidectomy. So that is the point, especially the elderly person, comorbidities, then maybe that is the preferred treatment that you do the surgical method. So what's your experience with doing the genetic testing? Are you in the practice of routinely doing the test like HRR, BRCA or MSI testing for these patients? Any of you?
Probably in metastatic CRPC setting when we have exhausted all the lines, not at front HSPC setting.
So Dr. Jay Mehta is sitting just behind you and he is listening very carefully that what sort of the things you are doing, complete HRR panel which just I have written for sake of the discussion or completion versus BRCA or versus doing only MSI at the time of the progression. So he will design or customize his NGS things accordingly. So do you add the next generation hormonal agents or chemo in every patient of HSPC? And there are very recently some data of combination of the chemotherapy along with the hormonal therapy. So anybody's experience from the panel or what do you think? Are you going to take up this in your clinical practice? So like abiraterone with the chemotherapy?
Maybe yes.
So if it is yes, it will be a sequential or it will be a combination since beginning?
Since beginning, Peace 1 trial, yes.
So Dr. Manish, what sort of the complications you are expecting when you start abiraterone acetate with low dose prednisolone along with the docetaxel in the very beginning?
In young and fit patient, there are tolerability may be good, but in symptomatic and older age patient, there are some complication may occur with both drugs. Docetaxel showing some hypersensitivity reactions and other along with if we give
so coming back to Dr. Rathod once again, that based on the PSMA PET which Dr. Sachin just advised that he will be doing the PSMA PET for every patient. So based on the PET CT scan, how you judge the patient to go for the local radiotherapy, prostate site radiotherapy in a case of the metastatic disease?
Sir, we usually elicit the tenderness in the spine in case of the spinal metastasis. Those having highest tenderness, we generally choose them first for radiation.
So going beyond that, in a metastatic disease, how you select the patient for giving the prostate site radiotherapy, the curative intent or the curative dose of the radiotherapy?
Sir, curative radiation we usually consider for early stage, low risk or intermediate risk of the prostate cancer. And we use moderately high fractionated resin, that is 75 grain 25 fractions or 60 grain 30 fractions.
So still it is not much in practice when the limited meds are there that you try to give them the radiotherapy. So I think that is the one thing we really need to consider for our patient. But in spite of this all discussion, I did the very conventional thing for my patient. I treated the patient with the gosling acetate along with the simple bicalutamide. So obviously all my panelists will differ it and they have given their view that they will like to go with the newer hormone therapy or they would like to go for the docetaxel probably. So coming back to again, my patient is too much confused now by taking the different opinions from the different medical oncologists. So let's summarize the things. There should not be any confusion after panel discussion. How you choose between the chemotherapy upfront versus newer hormonal agent. So two things are in my mind, that is the abiraterone and enzalutamide presently available. So I keep in my mind three things: docetaxel, abiraterone and enzalutamide. Do you agree with that? So how you choose, how you present the things in front of the patient or how you decide? Dr. Sachin, once again to you.
Sir, currently I am not using afferent all these molecules at the time of presentation with the androgen deprivation therapy. So I am using.
Can you have the proper mic? I mean.
Hello. Sir, presently I am not using these three molecules along with the androgen deprivation therapy. I am using them in sequential after the progression on the first line. So I think my colleague will be better.
So Dr. Manish, so how you select the patient upfront for the docetaxel?
Sir, docetaxel can be used in heavily burdened disease and visceral metastasis is present along with bony metastasis. And if patient having any seizure disorder, then enzalutamide can be defer, and few other symptoms, cardiovascular symptoms are common with abiraterone. So patient's history is important for choosing the.
Dr. Preeti?
So yes, I would like to add one of the therapies, docetaxel, abiraterone, and enzalutamide in hormone-sensitive prostate cancer. So the advantage with docetaxel is that it is a limited number of cycles, either 6 cycles 3 weekly or 9 cycles 2 weekly. The advantage, the disadvantage is chemotoxicity. The advantage with abiraterone is less chemotoxicity, but the duration is indefinite till progression. Both have shown overall survival benefit in Stampede trial. We have seen. Yes, we definitely would add docetaxel or any other form of treatment along with castration in hormone-sensitive prostate cancer, because there is definite overall survival advantage.
So if we, yes, Ankit.
Sir, what I follow is if the performance status is good, I definitely go ahead with chemotherapy, because as the disease progresses, most of the patients, their performance status decreases and they might not be able to tolerate toxicity of chemotherapy later on. So I try to include chemotherapy in the first line setting, and then I go ahead with abiraterone or enzalutamide in the second and the third line.
So based on the response to the PSA, do you try to classify the patient for the high risk versus low risk patient, like PSA becoming normalized within 6 months or something like that? Do you try to categorize your patient for subsequent treatment? So this patient, we had the repeat evaluation after some time, and there was a good response. But again, after certain times, there was the progression of the disease, symptomatology was there, repeat PSMA PET was done for this patient this time, and it showed the florid metastatic disease and more pain was there. So evaluation, PSA again started rising, but general condition remained all right. At this stage, again coming back to Dr. Ankit, anything new for investigation you would like to do for this patient? This patient initially treated with the combined androgen blockade only, and zoledronic was also given for this patient. After 9 months, patient had the progressive disease clinico-radiologically. So anything new at this stage you would like to do? How you will evaluate this patient at this stage, how you will evaluate the patient at the local prostate site also, to see whether local channel TURP or radiotherapy, palliative RT or anything else is required.
So basically I want to know whether the hormone agents that we had given was effective or not. Basically I want to know whether the patient has become castrate resistant or not.
Patient has become, sorry, couldn't get it.
Resistant or not.
Okay.
So basically
Okay.
a serum testosterone level should be of health,
Yeah.
and on that basis we can decide what treatment.
So how frequently or when do you evaluate the patient whether patient is actually castrated or not? Let's say surgical orchidectomy is not done, you have given some agonist or antagonist. So how you make sure, do you do the routine serum testosterone to label the patient as the CRPC?
No sir, I don't do it routinely. If the patient progresses, then only we get the serum testosterone levels done.
Yes, Dr.
Otherwise,
Rathod.
PSA
Sir,
levels-
consequently to persistent or rising trend of PSA over the 3 or 4 month apart, indicates regarding increasing trend of PSA,
Yeah.
and that patient is eligible to do the CRPC testings.
So I believe that in the present context of the availability of the various formulations from the various houses, with the due respect to all the pharmaceutical companies, even if it is so-called original molecule, I am of habit that if the patient is in scenario like what Dr. Rathod has just mentioned, it's always better that you check the testosterone level alike, label the patient in a proper way that castration resistance or the castration level is achieved or not achieved. Then only you move or call the patient as the treatment failure. So just to share or have the guidelines that the preferred treatments are abiraterone, docetaxel and enzalutamide. Depending on that what we have used in the first line, whether docetaxel is used or not, probably we try to use the second line. Now 2 important things which are coming in this field is based on the HRD panel or HRR panel, use of the PARP inhibitor, that is the olaparib or the rucaparib for that matter, and based on the MSI or NGS pattern. Sometime we try to give them the immunotherapy also in a rare situation. So these are the various treatment modalities probably presently available with us. So at this patient, patient had the progression of the disease. So cytotoxic drug chemotherapy was in my mind. So I started the patient with the pre-medication, proper pre-medication given, docetaxel. This time I switched to the denosumab because it was painful, and I continued the GnRH antagonist drug also. So I started with the conventional docetaxel, and patient had the anaphylactic reaction. Anyway, I could settle the patient with the ICU care, and patient recovered. So at this stage, will you switch the patient out of the fear to the newer hormonal therapy, or after 1 or 2 days you will again attempt the docetaxel same formulation with the better or prolonged pre-medication, or you would like to go the newer preparation or the newer formulation of the docetaxel? So 3 things are in my mind. So I would like to have the answers from the panelists. Dr. Gautam, once again. So either conventional docetaxel re-challenge, newer formulation, or switching to the hormonal therapy?
Sir, because now availability of the newer formulation, formulation of docetaxel, so it's difficult to re-challenge the patient, because he difficult to counsel him to re-challenge this drug. So we can offer him this formulation, new formulation.
So Dr. Preeti, do you agree that it's a difficult and patient may question why it was not used in the beginning itself?
Yeah, that is true.
So,
what answer will you say?
so these are the practical problems. The patient had the conventional docetaxel with me, and tomorrow he has come to you. So, and patient is willing to go for the docetaxel, and he always feels that Dr. Preeti Agarwal is a much better doctor than me, and she can give me the docetaxel.
But again, re-challenging with dosi is out of question, so it's very scary. Once a docetaxel patient...
So we do agree unanimously that probably the re-challenge is not a good idea. Maybe novel formulation or switch to the hormonal therapy, whatever in sequence is available. At this stage, if not docetaxel, would you prefer the conventional cabazitaxel available with us, with the history of the anaphylactic reaction, or you will prefer only nanolipid preparation of the docetaxel or the newer formulation of the docetaxel?
I think nano formulation, I'll prefer a nano formulation.
So, so that's the preferred. And what are the other problems other than the anaphylactic reaction which you feel that makes the newer preparation score over the conventional, other than the anaphylactic reaction or hypersensitivity reaction? Are there any other benefits?
I think the incidence of diarrhea is slightly on the lower side. Otherwise, I have not seen.
Dr. Sachin?
Mainly, sir, anaphylaxis is less as compared to the veins are also not as much damage in the nano as in the conventional docetaxel. So these are the two things.
So because the twin 80 or the alcohol are being eliminated, solvents are eliminated, so we need not to give them the conventional pre and the post high dose of the dexamethasone 5 days in totality. So that probably eliminates many toxicities also, especially in the elderly persons, diabetic patients and so on. So I think that's another advantage. And in clinical practice, routine way, how many percentage of the patients you are able to think of or giving them the newer preparation of the NDLS? Dr. Gautam, in your practice?
Sir, I have not used this
So
drug.
please be little louder. The company people are sitting behind and they are very keen to know your answer because they are making their strategy.
So sir, I have not used this drug. Only conventional docetaxel I have used.
So Dr. Ankit, I believe I have been given the feedback that you have the most richest patient in this area from the Udaipur belt. So what is the percentage of the patients you try to give them the NDLS?
Less than 1%.
Less than 1%. So I think that the message to the company people are very clear. They need to work more hard and they need to make their strategy that how the drugs can be more available to the more number of the patients to give the real benefit to our population. So this patient, I attempted the NDLS and patient tolerated well, and subsequent cycles were given. 3 weekly schedule, the PET CT scan was again done. There were regression of the disease, PSA also came down. One side there was a little more uptake, but there were no new metastases. So I took the patient as the responding the patient, I continued the treatment, and patient tolerated well. So I could complete 8 cycles of the chemotherapy. So in routine way, in a responding and tolerating patients, my 2 important questions to panelists are there. How many cycles you try to give in a metastatic setting in subsequent line, and whether you prefer 2 weekly schedule or 3 weekly schedule of the docetaxel. Dr. Sachin.
So maximum we have used 10 cycles every 3-week interval, not more than this.
So in a responding and tolerating patient, you yourself stop to the 10 cycles?
Yeah, as per guidelines, the 10 are maximum.
Okay. And anybody else comment, or do the panelists agree?
No, sir. Usually it is continued till progression or toxicity, but it is difficult to give after 10 cycles, as he says. It is difficult to give, but the guidelines say it is till progression or toxicity in CRPC setting.
So why this point is important? In the very beginning, we need to understand it, that going beyond certain number of the cycles, 6 to 9 cycles or more, is probably not possible with the conventional docetaxel, and that's probably possible with the newer formulation. I am very happy to quote one of the studies from our colleague from Jaipur, Dr. Asim Samar. He has presented and published the retrospective data collection of the efficacy and safety of the nanosomal docetaxel in metastatic castration-resistant prostate cancer. In this particular data collection study, both 2 weekly and 3 weekly schedules were taken, and patients tolerated treatment well, and dose intensity and everything was matching, and probably there was no much difference between the 2 weekly and the 3 weekly schedule. Both number of the patients were there, and there was a good percentage-wise decline in the PSA level, more than 50%, and if we calculate even more than 90% also. And here we can see that yes, safety wise also this preparation is well tolerated, whether we give 2 weekly or 3 weekly. So they concluded that both 2 weekly and 3 weekly regime was effective and well tolerated in this particularly scenario. Now coming to the discussion again, the bi-weekly docetaxel beyond 20 cycles, a case series has been quoted, and 3 patient studies there where they claim that they have given 3 weekly schedule even beyond 10 cycles or even beyond 20 cycles, and it was well tolerated also. So in a suitable patient or in a given situation, let's say the little younger patient, no comorbidities, well tolerated except the grade 1 or 2 toxicity, you can discuss with the patient and can go beyond that also. So if there is no other point, I would like to have the final comment from each panelist one by one, what they see something new or this sort of the preparation in the CRPC. Let's start with Dr. Rathod. What the new he feels that has come in the management of the prostate cancer?
So definitely a newer preparation will help to prevent so much anaphylactic reaction when using conventional care course of CRPC setting. So definitely nanosomal docetaxel is a good choice in case of CRPC.
Dr. Manish.
So along with the ADT, we should use another first line drug is my learning from this session, and docetaxel is well tolerating drug in spite of docetaxel.
So Manish, do you want to say that what I understood from you, that in a given scenario of the cost factor, probably the docetaxel in the first line is better with the defined number of the cycles?
Yes. Docetaxel is better drug.
Dr. Preeti?
Agree, sir.
Agree. So she also agree that docetaxel may be conventional, may be nanosomal, but she will prefer nanosomal.
Yeah, preferred in view of reduced anaphylactic reaction.
Reduced toxicity.
Reduced toxicity.
Yeah. So you won't get any call from the daycare where there's something wrong has gone to the patient, and you can go well from hospital well in time.
Yes.
That's very important. Dr. Ankit.
Yes, sir. I think the new formulation is very can be accepted very easily, but I think cost factor needs to be taken in care. But it's a new thing, and dosiacolib definitely will.
So let me make it in a little lighter vein, that you do the surgical orchidectomy, spare the cost of the agonist or antagonist, and invest that in the nanosomal preparation. Dr. Sachin.
Definitely, sir. Better and new preparations are always good, so we should use them judiciously.
If there is no more comment, and just a request to Dr. Jay Mehta also regarding the prostate cancer, would he like to add any comment or any new thing as far as the NGS or the molecular thing has come?
Yeah, so of late people have been asking for the HRR panel for that, because that would include the HRR genes, including the BRCA1 and 2. So that's recently started, yeah.
So we need to believe more and more in the molecular test, even for the prostate cancer. Yeah, and with this, I thank my panelists, every one of you, and we are happy that we are well in time. Thank you.
Thank you, Naresh sir, and thank you to the panelists. We'll now move on to our next session, which is lung cancer. And it gives me great pleasure to introduce our chairperson, Dr. Arvind Patidar, Senior Radiation Oncologist from Moderator. So can I request you to come to the first row? And I also request our chairperson to please introduce our first speaker. Over to you, sir.
Good afternoon. After going for that good panel discussion, again invite Dr. Naresh Somani sir to give an idea about what is the use of ramucirumab in stage 4 NSCLC, which is progressed after the platinum-based chemotherapy. Please, sir.
Once again, good afternoon to all of you, and thanks to Mr. Chairman to give this introduction. So, as the theme of this particular meeting is the Indian data, so I have purposely requested Dr. Manoj Mahajan that I would like to present something in which we were part of the clinical trial. And I'm very happy that he accepted my request. So, this is the original article with the Indian data reveal about the ramucirumab, which is a drug, anti-VEGF drug by class, and it is being approved in certain indications, including lung and gastric and so on. So this is ramucirumab plus docetaxel versus docetaxel placebo for second line treatment in stage 4 NSCLC after disease progression on platinum based therapy, reveal multicentric double-blind randomized phase 3 trial, and I am happy that I was part of this particular clinical trial. And this slide is basically to give the summary which has been presented and published in the Lancet journal about the original trial, that how it showed the PFS and the overall survival gain. So as we understand that ramucirumab is a human receptor targeted antibody that was shown to specifically block activation of the VEGF receptor 2. So, and it is little bit different from the bevacizumab. Now, this particular trial was NSCLC stage 4 patient after one platinum based chemotherapy plus minus maintenance, especially in the non-squamous cell patient. Prior bevacizumab was allowed. All histology, whether it's squamous or non-squamous, that's very important to understand. Both squamous and non-squamous were taken, and good performance status patient. Simple schema, ramu plus docetaxel, one arm, placebo plus docetaxel as a standard of care, another arm every 3 weeks. Ramucirumab here was the 10 milligram per kg body weight. Various stratification factors were taken for trial. And this is about the demographic baseline characteristic of the this particular REVEL trial in general. Now coming to the overall survival results of the original trial, 10.5 versus 9.1 months between the two arms were the difference in the overall survival with a significant p-value. Similarly, on line to that, PFS benefit was also there. Now, adverse events, if we look carefully, obviously the class effect will be more in the ramucirumab arm, but they were otherwise manageable and there were no new safety signals. And additional adverse events, as we understand, it's a VEGF drug, so hematological toxicity and the hemorrhage related toxicities will be there in this particular drugs, but there were no serious grade 3 and 4 toxicity. Now, with this original trial background, I come to the what we did the analysis of our patient. The REVEL study demonstrated the improvement in both PFS and NS, and our objective was to do the exploratory analysis of the safety and efficacy in Indian patient subgroup. So, total 55 patients were there from India in this particular trial. This was being published by Dr. Kumar Prabha's group from the TMH, and the male and female both patients were there. Obviously, non-squamous patients were more there. Good performance status patients were taken, and few of the patients had been exposed to the paclitaxel also in the first line treatment. So, the overall survival, PFS, objective response, duration of the disease control rate and various other parameters were taken for the analysis. If you look at the Indian data, overall survival, there is a difference, huge difference between the two arms, 13.5 months versus 5.29 months. Contrast to the 2 months difference in the total population, the Indian patient did well in the ramucirumab plus docetaxel arm. Similarly, progression-free survival, again there was the difference in favor of the study arm. And efficacy data, if we look at the overall survival, just to narrate again, 13.5 versus 5.3, hazard ratio 0.53, PFS 5.6 versus 1.5 months, and overall response rate was again better numerically, 27 versus 21 months, and the disease control, there was a huge difference. The stabilization of the patient's symptoms was very, very important, and that almost doubled in the ramucirumab plus docetaxel arm. And if we look at the toxicity, there were no new toxicity signals in the Indian subgroup of the patient. Obviously, toxicity were little bit more in the ramucirumab arm, but they were more grade 1 and 2 toxicity. And dose modification was again not much required between the two arms. That means the maximum toxicity in this kind of the scenario remains with the docetaxel, not with the ramucirumab. So, what was concluded, Indian patients enrolled in the REVEL study showed a trend of the prolonged overall survival and the PFS when they are treated with the combination, and this appeared to be the well tolerated by the Indian patients too. So, where do we stand as on today as far as this particular molecule is concerned? If you look at the guidelines which we commonly follow, that is the NCCN guidelines, whenever after the first line treatment, whether patients are treated with the chemotherapy plus minus immunotherapy, yes, immunotherapy always remains a preferred treatment in the second line if not given in the first line, but we know that there are certain contraindications, other reasons that we are not able to give the immunotherapy, and whenever we prefer the docetaxel in the subsequent line of the treatment, whether the second line or subsequent line, I think in a good general condition patient, select group of the patient, docetaxel plus ramucirumab should be the standard of care for our patient. Thank you.